Hello, I am Dr. Khalilah Jefferson, DNP. Today, I want to discuss the infection we don't talk about, why bacterial vaginosis deserves a new conversation. What if I told you that one of the most common vaginal infections in the world is not officially classified as a sexually transmitted infection, yet it increases your risk of getting one? That infection is bacterial vaginosis, or BV. Globally, millions of women experience BV each year. In the United States alone, prevalence estimates suggest nearly 1 in 3 women will have it at some point, and yet BV sits in a strange gray zone of medicine, common, recurrent, clinically significant, but socially minimized. Let's first understand what BV is. BV is not caused by a single invading organism. It is a disruption, a shift in the vaginal microbiome. Healthy vaginal flora is typically dominated by lactobacilli, protective bacteria that maintain an acidic environment. In BV, those protective bacteria decrease and anaerobic bacteria overgrow. The result: discharge, odor, discomfort, or sometimes no symptoms at all. But here's where it gets more serious. BV is strongly associated with increased risk of acquiring sexually transmitted infections, including HIV, chlamydia, gonorrhea, herpes, and HPV. It's also associated with pelvic inflammatory disease, infertility, and adverse pregnancy outcomes such as preterm birth. So the question becomes, if BV increases susceptibility to STIs, if sexual activity influences its development, if recurrence is common in sexually active individuals, why don't we classify it as a sexually transmitted infection? Historically, BV has not met the traditional criteria of a classic STI. It can occur in individuals who are not sexually active. It is not caused by a single pathogen passed from person to person in a straightforward way. And male partner treatment has not consistently reduced recurrence in women. But emerging research challenges that simplicity. BV prevalence is strongly associated with new or multiple sexual partners. It is more common among women who have sex with women, suggesting partner to partner microbiome exchange. Recurrence rates decrease in some studies when both partners are treated, and reinfection patterns resemble transmission dynamics. In other words, while BV may not fit the old STI model, it behaves in many ways like one. And classification matters. When something is labeled an STI, it changes screening practices. It changes public health messaging. It changes funding priorities. It reduces ambiguity in counseling. It reduces shame by replacing hygiene myths with evidence based science. Right now, many patients are told BV is about soap, douching, or cleanliness, but BV is not a hygiene failure. It is a complex microbial imbalance influenced by sexual networks and biological vulnerability. By hesitating to recognize BV within the broader STI framework, we may be underestimating its public health impact. We may be missing opportunities for partner based interventions. We may be perpetuating stigma through confusion. And perhaps most importantly, we may be failing to communicate risk clearly. This isn't about forcing BV into a box. It's about evolving our definitions as science evolves. Sexual health is not binary, STI or not STI. It exists on a spectrum of transmissibility, susceptibility, and microbiome interaction. BV sits squarely in that spectrum. So maybe the better question isn't, is BV technically an STI? Maybe the better question is, does our current classification system help patients understand risk, protect themselves, and receive comprehensive care? If the answer is no, then it's time for a new conversation, because when science advances, our labels should too, and women's health deserves nothing less.